Hi, good morning. This is John White with Frederick and Company, sponsors of the World of Private Offerings. Every day, 300 million people wake up suffering from the affliction of peripheral neuropathy. 40 million alone just in the United States. Today, we have a guest that's going to speak not only about this disease, but how his company has researched, developed, and now using to treat people with a non-drug solution to relieve the symptoms of this disease. I'd like to introduce now Phil Walter of Biolyst, Minneapolis, Minnesota, and he can discuss not only this, but also a breakthrough technology that this company is now essentially bringing to market. Good morning, Phil.
Thank you, John, for that introduction. Start over. Thank you, John, for that introduction, and thank everybody for participating in this seminar. I hope to be informative about peripheral neuropathy and give you some useful information. I also hope to intrigue a couple of you into looking closer at Biolyst as an intriguing and very unusual investment opportunity, very attractive one at that. Biolyst is the name of the company, and Relief Therapy is the name of the therapy that we have developed and licensed to practitioners around the country. So let me start at the beginning and talk about what peripheral neuropathy is. It afflicts about 40 million patients in the US and about 300 million worldwide. This is a disease of the peripheral nervous system. It's very common, very prevalent. It is a chronic disease in that it has no cure and there is no disease-modifying therapy available. It is progressive in that the symptoms just keep getting worse over time. And it's often debilitating because these symptoms, this progression leads to the severity of symptoms that debilitate patients and make them unable to live a normal life. It is triggered by diabetes. About 70% of diabetics will get neuropathy. The majority of chemotherapy patients will get neuropathy, as well as dialysis patients. There are also many prescription drugs that will trigger it. Statin drugs, for instance, or some antibiotic drugs like Levaquin and Cipro. Those will trigger it. There's about 100 things or more that will trigger peripheral neuropathy. The symptoms can be confusing because they depend on which nerves are involved and to what degree. Pain is very often associated and thought of in terms of neuropathy, but that really afflicts only about 20% of the neuropathy patients. Numbness is by far the more common symptom and can be the most debilitating symptom. Now, numbness sounds rather innocuous, but in fact, numbness means also a loss of proprioception ability, and that's your brain's way of knowing where your foot is when you're not looking at it, for instance. So that allows you to walk or get on an escalator or jump without looking at your feet, without knowing, precisely having to look at them visually to see where they are. It also means that you can walk down a hallway without bouncing into the walls, and you can turn around without falling down, etc. That's proprioception. Along with loss of proprioception comes loss of protective sensation, and that can be even more serious in one particular case. If you are otherwise normally healthy, you have neuropathy, but otherwise you're in good shape, and you have shoes that don't fit right and they cause a blister, or you step on a piece of glass and you get a cut. If you're otherwise healthy, that's going to heal itself even if you're not aware of it, if you've lost the feeling in your foot. But if you're a diabetic, that may not be the case. For a diabetic, an injury to the foot that is numb can be very serious because they don't know the injury is there, and the diabetes will, in many cases, keep it from healing. So that injury becomes ulcerated. That injury, the only thing ultimately that can be done with that injury is amputations. And I'm going to talk more about this and how severe this is to that patient. But other symptoms of neuropathy include burning, tingling, hot, cold sensitivity, etc. So again, it depends on which nerves are involved and to what degree. What's available to fix it? Nothing can cure it. The standard of care, which is those things that are approved by the FDA for this condition, consists of repurposed drugs, and the two that are approved are Cymbalta and Lyrica, although Neurontin is also used off-label as our opioid drugs for the pain. But these drugs, therapies, only address pain, and they don't do a terribly great job of it because the majority of patients that take these drugs do not get any benefit, don't get a reduction of pain. Those that do get a reduction of pain get about a 30–34%, just a little bit above placebo rate. About a third of the patients that take the drug, whether they get a benefit or not, report adverse side effects. And these drugs have no effect whatever on any other symptoms other than pain. So if pain's not your primary symptom, these drugs are not going to do anything for you. There are alternative modalities on the marketplace. There's a lot of advertising for lots of things to help with neuropathy. These include TENS units or LED arrays or class 3 cold lasers, those are called sometimes, acupuncture, hypnosis, nutrients, etc. All those things are marketed out there as solutions for neuropathy. The problem is they don't show any evidence, real clinical evidence through randomized clinical trials that they do anything, and certainly anything durable. So there's a problem. So what is relief therapy? That's the name of our therapy. Relief therapy is an approved therapy that employs, this is a long-winded definition, but bear with it, that employs a titrated treatment protocol to drive a class 4 therapeutic laser to stimulate biochemical processes, the outcomes of which are pain reduction, reduction of edema or swelling, increased blood flow, and accelerated healing. Those outcomes are well documented in the medical literature. They've been known and validated for a long time. However, applying this phototherapy to nerves is a whole nother kettle of fish. It's not so simple, and I'm going to describe how you go about doing that properly. But the therapy itself is non-invasive. There are no drugs involved, and there are no adverse side effects. There are some fine print you got to be aware of in that definition. There are 3 essential facts to understand. First of all, a therapeutic laser is not a surgical laser. The laser we use will not harm any tissue. We don't collimate the beam sufficiently to create enough heat to damage tissue. No harm done. The second thing to remember is that phototherapy is biphasic. What that means is if you apply too little, you get no result. If you apply too much, you get no result. You have to be in that Goldilocks zone, what is called in medicine the therapeutic window. If you're not there, you don't get a consistent result. You may by dumb luck, but you don't get a consistent, repeatable result. Therefore, the essential determinant of efficacy is not the laser. There are lots of people out there with lasers, class 4 lasers, claiming to treat peripheral neuropathy. If you don't have a titration method to go with it, and therefore the protocols that derive from that titration method, it's not going to help. It may help by random chance, but it's not going to be consistent. It's not going to be repeatable. Because phototherapy is biphasic, titration, that's the process of getting the fine-tuning of all the variables that go into that laser, is necessary to be able to get each parameter of the light and delivery just right to hit the therapeutic window, that Goldilocks zone, and achieve the desired outcome. Each patient is different, and each treatment for each patient is going to be different, and that's the hard part, because it has to be done over and over again each time the patient comes in. So let me describe what it takes to titrate a class 4 therapeutic laser for peripheral neuropathy. First, you have to gather big data. What I mean by that is you have to have a database for algorithms to look at and work with that is massive. To do that, we created a clinical software that we put in all our clinics, and those have been collecting data, all of our clinics, for many, many years. We have the largest patient registry in the world for peripheral neuropathy, and I'll describe that in a minute here. But that collects data through a discipline of managing and guiding an exam in which the practitioner has to collect certain information, put it in the system. That goes into a patient registry. That data, and that consists of signs, those are things that are measurable without the patient input. Symptoms, those are things that the patient reports, and the rate of change of those over time, because each time the patient comes in, they're different. Those values for those signs, symptoms, and rate of change are assigned to each of 36 area zones on the body. We deal with arms, legs, hands, and feet. So for instance, the bottom of the feet is six zones. Each zone, each of the 36 zones has a profile of these signs, symptoms, and rate of change built up. And again, that changes over time. That's how the data is all organized. That paints a picture of the patient, and then the artificial intelligence algorithms that we have designed use that profile of the patient, that picture, and compare it to all other patients that we've treated, and find those values of the parameters of the laser application that were the most effective and most important for the outcomes that are desired. And then it uses that information to construct the protocol for this patient right in front of it. right? So every treatment is going to be different. Every patient is going to be different. The protocol that results from this is the actual parameter values of exposure applied to any treatment. So they include power density, that's how many photon packets of light are in an increment of the light, exposure time for every zone, every surface area zone, the surface area itself, what is it, and in what order are they treated? Remember, there's many of them. The wavelength of the laser beam and the pulse structure of the laser beam. Those are all important variables. They all make a difference to the outcome, and they all have to be just right. The laser itself is slaved to the cloud-based software. In other words, the therapist giving the therapy is not the one that sets up the computer. It's the artificial intelligence algorithms that determine what the variables should be, and the software then sends down to the laser over the cloud the proper instructions for how to set itself up to get the right result. The therapist then just has to paint by the numbers. Pretty simple process. Our relief therapy consists of 2 phases. The phase 1 is the most intense. That's the patient comes in day 1 with lots of symptoms. Maybe they're in a wheelchair, they're using canes, whatever. They come in, they're going to go through a cycle of about 14 treatments. That's the average, sometimes more, sometimes less. Average of 14 treatments, about every other day. Sometimes it's compressed a little bit, but about every other day. So that's about a 5-week regimen. At the end of that 5 weeks, those symptoms, all of them, should be down to, and normally are down to, about the subclinical level where the patient is no longer aware of them. So in other words, if the patient is debilitated, maybe they're in a wheelchair day 1, normally at the end of the initial course of care, their symptoms are behind them. They don't register any more symptoms, right? They're not in their wheelchair anymore. They can function normally. At that point, we have not cured the disease, and this is a progressive disease. It's going to keep trying to come back. So those symptoms are going to try and get worse over time. So we have the second phase, which is the maintenance care phase, in which a patient comes in 2 to 4 times a year to the clinic and gets an additional treatment, and that will keep the symptoms down to that at or near that subclinical level. I'm going to show you some data on that as we go. But let me talk about first that registry data, where all this is. We have the largest patient registry in the world for peripheral neuropathy. We've been collecting out of our centers since 2011. We have over 2,100 patients in that data set, 40,000 treatments, and over 6,000 data points per patient. So an awful lot of data. Just to give you a frame of reference, our data set is larger by twice what the next largest data set is for peripheral neuropathy patients, and it's more granular, more detail, by 240 times that next largest registry. So ours is the only registry structured in a way to be used for titration, the only one. That registry shows us significantly positive outcomes right across the board, and this has all been validated by the Mayo Clinic's Biomedical Statistics Group. It shows significantly better results than standard of care, the drug therapies. It also correlates very nicely to a randomized clinical trial that was done at the University of Minnesota. I'll get into that in a minute. And interestingly, it doesn't matter where the neuropathy came from, what triggered it, it responds pretty much equally to across all the etiologies. So whether you have diabetes-induced or chemotherapy-induced neuropathies, they will react the same way to this therapy. And it's now considered predictive of future outcomes, which makes it very useful for us for doing future clinical trials because we know the results before we even start. The first, I want to talk about another way to validate our system. Since we have so much data, there is a measurement tool called the Neuropathy Total Symptom Score, NTSS-6, that is used in the medical circles to assess and measure the intensity or the damage being done by peripheral neuropathy, the level of impairment, if you will. This is well-published, well-validated and accepted measurement of neuropathy. It's been used in many clinical trials, including the FDA's trials, etc. Any score in this measurement is considered, above 6, is considered to be an impairment. Any therapy that reduces this score by 1 point is considered to be significant by the FDA. Now, this measurement is no longer used simply because no one's ever been able to move it. It is a good measurement tool. No one's been able to affect it. When we apply this measurement tool, and we collect exactly the same data, to our registry data, pre to post therapy, we see that we can move that and reduce that score by almost 5.5 points. Very significant, very provocative validation of our data. The second validation that I want to talk about has to do with diabetic foot ulcers, and I'll digress a minute and tell you why that's important. About 20% of diabetics are going to get a diabetic foot ulcer, statistically speaking. About 17% of diabetic foot ulcer patients undergo amputation within 12 months. This is the leading cause of non-traumatic lower extremity amputations in the United States. Over 15% of these patients are going to die within 12 months. And only half the patients with diabetic foot ulcers will survive 5 years from diagnosis. This is a dramatically serious problem. Diabetic foot ulcers correlate very highly to numbness caused by peripheral neuropathy. This is why numbness is so important as a symptom. So the second external validation I want to talk about then has to do with diabetic foot ulcers. There is a scoring mechanism called the Neuropathy Disability Score. It's used by endocrinologists. It's a test given to their diabetic patients. It is considered to be very accurate for predicting the risk of diabetic foot ulcers. The higher the NDS score, the higher the risk, etc. When we take this scoring mechanism and we apply it against our registry, because we collect the same data, we show a 59% reduction in the NDS score pre to post therapy. This is a very provocative point of data, suggesting that we might have a very significant impact with our therapy on the incidence of diabetic foot ulcers. The third validation, external validation, is the gold standard. This is a randomized, placebo-controlled, double-blinded clinical trial. The University of Minnesota Medical Center Oncology Department conducted such a trial. It was a randomized, double-blinded, placebo-controlled trial. The results were peer-reviewed and published in a medical journal in January of 2017. Once they collected and enrolled all the patients into this trial, they were randomly sorted into one of two groups. And in phase 1 of the trial, the one group was treated with relief therapy. The other group was not treated. They were given sham treatment. In other words, they thought they were getting treatment, but they weren't. So everybody was blinded. They didn't know whether they were getting it or not. And then the measurements were taken throughout the course of the trial, and then 16 weeks later to determine how it stuck. At the 16-week point, then the group that got the sham treatment, they were crossed over. They were given the real treatment to see what happens to their set of symptoms. So this is the actual data that was published, or this is the graph in that published data. The two vertical shaded areas are the phase 1 and the phase 2. In the phase 1, there was a sham group that got no treatment, and of course, over 16 weeks, their symptoms got worse measurably. That's to be expected. It's a progressive disease. The group that got the real treatment, however, their symptoms universally, and this is a composite score of all symptoms, dropped down to subclinical levels. The patient was no longer aware of symptoms. And then they started climbing back up at the 16-week mark, right? Then at the 16-week, the sham group was given the real treatment. Their symptoms likewise dropped, just like the first group, and then started to come back at the 16-week point. So the conclusion I can draw from this is the therapy really does work. It drops all symptoms very quickly down to subclinical levels. The question I have is what happens over time? Do those things just come back? Because this is a progressive disease. This graph answers that question. I said earlier we have two phases. We have an initial care phase, and that's the line over here on the far left-hand side, precipitous drop in symptoms all the way down to the end of the initial course of care. That's time 0 for the maintenance phase. And then we have a maintenance phase, and as long as a patient comes in 1 or 2 times a year, sometimes it's more, sometimes less, they will maintain those symptoms down at that level. This graph shows data for 36 months, 3 years, and every single month in this data includes over 100 patients that are getting a maintenance treatment that month. So that's very dense data with a lot of patients in it, but you can see we keep them down at those levels. Very impressive results. This is a numeric comparison between Lyrica and Cymbalta, the two approved drugs, versus the outcomes of the trial at the University of Minnesota. Since the drugs are chasing pain and pain only, the non-responder rate for pain, that's people that didn't get any benefit, was pretty significant for Lyrica and Cymbalta, 50 and 67%. 0% for relief therapy. In other words, 100% of the patients that had pain got relief of pain with our therapy. How much relief? Well, Lyrica and Cymbalta got just a little bit above placebo rate. Our patients got 94% reduction in the pain symptom. Placebo rate, again, for the drugs is 30%. It was 3% for relief in this trial. Mean mitigation of numbness, tingling, and sensitivity. no results at all for the drugs. They didn't affect those symptoms at all. We got very significant reductions of those symptoms without any adverse side effects. And of course, the drugs had about a third of the patients getting adverse side effects. So let me just kind of summarize the business and the expansion plans. There is no other disease-modifying therapy available, and symptomatic therapies are only marginally effective. Biolyst is the first to market with a disease-modifying therapy. It is a safe, significantly more effective, non-invasive, non-drug therapy, and there are significant barriers to entry for any competition. The biggest significant barrier is not just our patent application, it is the titration method and the data that you have to have in order to even think about doing titration. No one else has got that. We've got over an 8-year lead collecting that kind of data, and no one is chasing us. We are currently raising investment money to expand the company-owned clinics to all major markets. Now, those are going to be patient pay centers initially. We have investment opportunities for both large and small investors, and the investment funds are going to support clinic expansion and the process by which we get Medicare and insurance approvals down the road. Those are possible in the range. We start to get regional approvals in the range of 5 years. That really sets the tone for the big payoff for investors. So that's the presentation. I hope I've answered any questions you might anticipate, but just in case, I'm going to turn it back over to John, and we'll do a Q&A session. Thank you.
Well, thanks, Phil. That was terrific. Okay, I got a couple questions here for Phil, just in general. First one I see a couple times in there. Not only will there be a link to the presentation, but also people have now requested, can they get a hard copy? Yes, when we send the link out, we'll also send you the hard copy, or essentially the digital copy of the presentation. So let's, I've got a couple of questions here, and one of the more prevalent ones is how many clinics do we have open at this particular point?
Right now we've got 7 clinics in the U.S., and once we have our Series B funding in, we're going to expand with company-owned centers around the country. In the first year of funding, post-funding, we'll open 4. To get our feet wet, if you will. It takes us special staffing to do that. So we'll open 4, and then it goes to 12, and then 24, and 46. That's going out. So that it'll be a pretty aggressive schedule out in out years. But you have to phase company-owned stores in. It takes about a little bit over $500,000 to fully fund first-year operation of a new clinic. And that's staffing, equipment, everything else. And on that, in the first year, you have a loss, a net loss of about $50,000. And then in the second year, you have a profit of about $400,000. In the third year, it goes up from there. So you have to phase in the new clinics in such a way that the ones that are there for more than a year that are profitable are paying for the startup loss years of the new ones that start up. So there's a phasing issue there, but we start out, right now we have 7. Those are all independent clinics. The ones going forward will be company-owned clinics, and we'll start out with 4, 12, 24, etc.
Yeah, and also another question came in and said, how many patients to date have been treated?
We're pushing up to 2,200 patients now. So our patient registry, and that's all the patients that have gone through at least 6 treatments, and that's about 2,151 as of a few weeks ago. So it's moving up toward 2,000 patients. Now, keep in mind, we've got about 6,000 data points on every single one of those patients through the initial course of care. That makes our registry data about 240 times more dense than the next largest patient registry in the world. And it's the only registry that is structured in a way that you can do titration with it.
I think this next question, Barbara, you could go together. One was basically wants to know the difference between the lasers they saw in a chiropractor clinic, and there's also some questions as to, I think people were curious as to, had a couple questions as to the use of artificial intelligence. So maybe you can address that one.
Yeah, those are good questions. What you might find in a chiro's office could be a class 3 laser or a cold laser. Cold lasers are defined as those lasers that produce less than a half a watt up to a half a watt of energy. The wattage is a function of the measurement of how many photon packets there are in each amount of light. So a class 3 laser is very common to see. Class 4 laser is less common, but you do see them. The problem with the class 4 laser in a chiropractor's office is that chiropractor does not have any way of titrating that laser. So what they're very good at is using those lasers to resolve soft tissue damage, tendonitis, sprained ankles, general swelling, etc. Very good at that, and it's very easy, and it doesn't take any titration methods to do that. But when you get to nerves, trying to recover nerve function, that's a different matter. The chiropractors simply don't have the data. First of all, you have to have a lot of data. So no chiropractor has a data registry to gather a couple of thousand patients and all of the data that you need with those. And furthermore, doesn't have the algorithms to go walk through that data and figure out what's going on. So let me address the algorithm. In what I call 1.0 version of computing and software, if you could describe how to do something, then you could write a set of instructions to the computer, so the computer would do it. Once we had lots of data in our data set, we then converted to artificial intelligence or machine learning algorithms. What that means is you no longer write a set of rules. What you do is you give examples to the software of what you want as an outcome, and you let the algorithms go into the data set and look for the patterns and the connections and sensitivities of all the variables that lead to the outcomes that you said you wanted. So the computer can do that much better than the human mind, much quicker. We can't process that much data. So they're looking for all the little connections among all the other patients that have been through the system that are like you, like the new patient, and they're finding out those things that mattered and how much they mattered in the treatment, and that's what is applied to this new patient and the first. And that process of looking for all the variables and the sensitivities and the values, that has to be repeated each and every time they come in, which is another difference between what we're doing and what that chiro with the class 4 laser is doing. Because that chiro is using the same protocol for everybody each time. You go to that chiro, and you have symptoms below the ankle, numbness or pain or whatever your symptoms are, he or she is going to treat that below the ankle. And they're going to give you 30 minutes or 10 minutes or whatever they decide. If they're using a pre-programmed, if lasers a pre-programmed 8-minute cycle, etc., they're going to do that same thing for each patient each time they come in. And that the problem with that is that you don't. That's what we call a dumb luck protocol. You can line up 10,000 diabetic patients, give them all the same dosage of insulin, and just by dumb luck, some of them are going to be better. The problem with the dumb luck protocol is it's not consistent, it's not repeatable, it does not generate the same results at all. So without titrating that laser, you really are not going to get the kind of results you expect and want and patients need to get. And that's the problem without having the data, without having the algorithm, you can't get the results.
Well, maybe we can describe Biolyst as more or less an artificial software company that learns how to treat these symptoms that also uses lasers, which I think is a very distinguishing. So the laser is just a means to an end. I think that's excellent. Also, the questions came in: how much does it cost for, say, for an individual patient at this point? And also, maybe we can combine that with another question of not only the current cost, but when do you anticipate Medicare to and other insurance companies to essentially participate in this type of treatment?
Very good questions and pertinent. Right now, all of our clinics, our 7 clinics, are independently owned by practitioners, so they set their own price. But the ranges for the initial course of care, and that's an average about 14, 15 treatments. For that initial course of care, the prices range about $3,000 to about $3,600. And then when a patient comes in on maintenance phase, those could be $150 a visit to $200 a visit, somewhere in there. Again, the prices are set by the practitioners themselves, not by Biolyst. But that's about the ranges that we're seeing that have been applied out there. Medicare, private insurance companies, Medicare are that is a well-defined but a long process to get there. We're going down that path. We're well down that path already. But we have another few years to go before we're there. First of all, by requirement, by protocol, we have to, we're going to undertake 2 small biomarker trials. Those are next up, and those are already ready to go. And then we'll do 2 very large multi-site trials, and those take a year and a half or so to get done. So we're talking, I would expect we'll start getting regional determinations for Medicare, which also means private insurance. I expect to start seeing those come in about year 5 from company. Maybe year 4, but certainly year 5 I expect to see that. Once we see that, you'll see the private insurance companies that follow Medicare. In the meantime, right after we finish the biomarker trials, we're going to start moving toward some of the private HMOs, some of the Kaiser Permanentes and etc. Try and get provisional determinations from them in their systems and build up more data for Medicare. So it's a process. It's a lengthy process. Fortunately, we have an advantage that most other medical startups don't have. And we can be a profitable commercialized company with a patient pay system before we reach Medicare reimbursement stage. So that is how we're proceeding, but it's going to be a few years before insurance companies cover it.
Here's a couple questions that came in terms of the investment. So there's a series of, so basically you stated that the company's open for investment. At this particular point, not only so, and another question came in as to how much capital is going to be required to have you reach your goal, and in probably combining one other aspect of this is, and I'll add my own thing from the investment banking standpoint is that when do you expect to have cash flow and profitability, in terms of with this investment capital.
Overall, to get to the end game, to get to the end stage, Medicare reimbursement, FDA labeling, etc., it's going to take about $20 million, $19 to $20 million to get us there. So that's what we're out raising. Now, in the short term, we have, for smaller investors, we have a vehicle that we're going to get $1 to $2 to $3 million in essentially bridge funding mechanisms there. That profitability is based on how quickly you open up company-owned clinics, because again, the first year of any company-owned clinic is going to be a net loss, so you have to factor that in. Plus, we're going to be hiring a lot of people and doing a lot of investment in clinical trials to get to the Medicare, etc. So we're looking at about 3 to 4 years profitability, and then from that point, it really hockey sticks, because the minute you get the first Medicare regional determination, the patients are just knocking down your door, and really our challenge then is going to be, do we have enough centers to service all the demand? Because there are 40 million people in this country alone that need treatment. There is no place to turn. So once we have Medicare reimbursement rate assignment, then the doors kind of go off of it. But it'll be a few years of profitability, but overall, about $19 to $20 million gets us to the end goal. Medicare reimbursement, etc., and a very nice profit stream starting midway through that cycle.
Well, I think that's most of the questions. To kind of wrap it up a little bit, is that Phil is open and his staff is open for anybody who wants to call and to discuss anything about the technology. And again, and of course, obviously anything about the background and features of the company. Phil's more than capable. Here, we're going to be contacting you from Frederick & Company, everybody who's registered today, in the next couple of days to answer any more of your questions. And I can wrap up a little bit too about how we see as an investment banker this perspective opportunity. One of the things we look at in these type of medical technology breakthroughs is that there's lots of great projects out there, but there's long development cycles before they get FDA approval, before they can take any money. Here, we see in Biolyst, not only does it have a proven track record of treating patients, but also it has the opportunity, as it's developing a market prior to any type of insurance or Medicare approval, which again is like Phil referred to, and this is what we see, which why we think this is an excellent investment in terms of return on investment. A market gets established, even established profitability, But then once the insurance and FDA markets and get in Medicare type of kick in, it's a hockey stick, because again, it's essentially, it might become, and it will have a very good opportunity to become the de facto standard of treatment, far more effective than drugs. And now we're only just talking about the U.S. marketplace. And Phil, and maybe in a future presentation, we can discuss some of the other opportunities that even exist in other parts of the country, because again, it affects countries, people all over the world. Okay, so again, thank you for your participation. Again, we'll be sending information out as to where to get the presentation and how to get more information going forward, but we will be in touch with you. And thanks again for Phil for a great presentation, and we'll talk to you very soon. Bye now.
Thank you, everybody.